So we're going to go ahead and get started. Our last panel of the day, and thank you very much for your persistence and your dedication. The topic of our panel is defaults in healthcare. My name is Greg Curfman of the New England Journal of Medicine. Our first speaker is Anna Sinaiko at Harvard School of Public Health, and she will presenting some empirical research on selection effects versus default power, the choices of terminated Medicare Advantage clients. And Anna, I assume the clients are not terminated, but the Medicare Advantage is terminated, correct?
That is correct, yes. Thank you all for coming. I'm very pleased to be here today to present some work in progress. This is new work, and as we spent the last day or two talking a lot about choices people make and choice architecture, I want to refocus or talk very specifically about choice in a certain context. And so this paper, Terminated from Medicare Advantage, Now Choose, is asking us to think specifically about people who are in a market for a good or a service, and in this case, it's a health insurance market where you're choosing a health plan, and they've made a selection in a prior period. But the selection that they made becomes no longer available, and so to stay in the market, they need to choose again. And so this is work I'm doing with Richard Frank and Richard Zeckhauser. We're grateful to funding from the National Institute of Aging for this work. And I'll start out by talking just a little bit about the fact that as we've seen a transition really over the last decade towards health insurance in the US being sold increasingly in marketplace-like settings, that the number of plan terminations that are going on in the market are increasing and leaving an increasing number of enrollees in plans that are terminated. So I'm going to call these people terminated choosers, or TCs. The choice that they made in a prior period becomes no longer available. The individual market for health insurance in the US is quite volatile, and so there's a lot of plan exit and entry in general, and I think we've all probably heard in the media in the last year about the discussion about plan terminations that's occurring as a result of individual market plans not meeting minimum requirements stipulated by the ACA. In the Medicare program, which is the focus of our work, there's the Medicare Advantage program, which we'll talk about in a little bit, but also there's TCs that are created in Part D. This is the market where Medicare beneficiaries obtain prescription drug coverage by choosing a private prescription drug plan. And so as those plans exit the market, enrollees need to choose again. Medicaid beneficiaries aren't exempt either. States increasingly rely on Medicaid managed care plans to provide Medicaid coverage. And then also even in the workforce, we can imagine more and more private workers becoming TCs as the extent to which employers start to shift workers over to private exchanges, which some people think will start to happen. So I tell you all of this as motivation for this paper, that there are increasingly large numbers of TCs in the US health insurance markets, and so we really want to think about them as their own class of people. And we do two things. The first is look at what do TCs do? What sort of decisions do they make when they find themselves in that situation, and the extent to which their choices seem to deviate from those that the rational model would predict. So do we think that they're potentially making decision-making errors? And given that, what should we do? As we think about choice architecture, there are implications for choice architecture, not only because of people making choices in an original case, who I'll call original choosers, but also TCs, or terminated choosers. Turning to the Medicare Advantage program, that's what we've studied. Medicare Advantage is the program that allows Medicare beneficiaries to enroll in a private health plan for their health insurance coverage instead of obtaining coverage through traditional fee-for-service Medicare. And the way that this works is when you turn 65 and you become eligible for Medicare, if you do nothing, you're automatically enrolled or defaulted into traditional fee-for-service Medicare, but you have the opportunity to elect to enroll in a Medicare Advantage plan instead. If you don't do that, or once you make your choice, then you can change once a year during open enrollment. for the rest of your time in the program. Medicare Advantage is an important program. It's large, there's a lot of plans, there's an increasing number of enrollees in the program, but there's a lot of flux in the Medicare Advantage program. And in particular, over the last decade, due to changes in plan payment and in regulation that have been enacted through legislation, there has been a real change in the number of plans available to beneficiaries. And importantly for us, this change in the number or the supply side of plans has varied across counties. And so when we looked at Medicare Advantage plans that offer Part D coverage, so MAPD plans as they're known, we observed 234,000 TCs in these Medicare Advantage Part D plans over a 4-year period from 2006 to 2010. So now I just want to take a minute and talk about why TCs are different than original choosers in Medicare Advantage. And when I say original chooser, again, I mean somebody who's entering Medicare and selecting whether it be traditional Medicare or a Medicare Advantage plan for the first time. So the first reason is that TCs have, in a prior period, overcome the default in the Medicare program, which was to enroll in traditional Medicare. What we learned by them doing that is not only do they have the ability to actively choose, but that they have a revealed preference for health insurance to be delivered through a private health plan as opposed to through the traditional program. And then the last point is that as these individuals have been in Medicare Advantage, their preferences may be affected by status quo bias, which serves to further or augment their preference perhaps to stay in Medicare Advantage. I think that there's probably a lot of cases of TCs where all 3 of these conditions apply, not all of them, but they certainly apply here. But not only are TCs different than original choosers, they actually look pretty different than most other Medicare beneficiaries who we can observe in enrollment and claims data. So here I'll present some findings. This is descriptive work, and each column shows you a different type of beneficiary. So in the far left, we've got TCs who enrolled in an HMO in 2006 in Medicare Advantage, and then that plan was terminated. And you can see in the top part of the table that in that subsequent year in 2007, 5% of those individuals went into traditional Medicare. The remaining 95% stayed in Medicare Advantage. And the bottom part of the table shows you how that 94% sorted across different types of Medicare Advantage plans that were available to them, about 2/3 into an HMO and 1/3 into private fee-for-service plans. So moving to the right, the next column shows you voluntary switchers. These are also enrollees in an Medicare Advantage HMO in 2006 who voluntarily elected to change out of that plan going into 2007. This group looks pretty different. Now, their change was motivated by something that happened to them. We don't know what it is. Perhaps it was dissatisfaction with their experience in their plan or with Medicare Advantage overall. But there's a much higher rate among this group of going into traditional Medicare, 16.5%. Relative to staying in Medicare Advantage. And then within the Medicare Advantage program, they also sorted quite differently across plans. Stayers, by definition, are people who didn't leave Medicare Advantage. They've also sorted across Medicare Advantage plans differently in the bottom part of the table. And as I mentioned, original choosers look quite different. A much, much higher portion of them go into traditional Medicare at age 65 than into Medicare Advantage overall. So when we think about what are the policy alternatives, the potential choice architectures, possibilities for TCs in Medicare Advantage, the first we're calling straight choice. Now, after being here for a couple of days, I've realized there are different ways of calling what really are, we're talking about similar policies. I think this is akin to the active choice that Professor Sunstein spoke about yesterday morning. This is where we essentially say your plan has left the market, you can choose a new plan, but if you don't enroll, then you have no coverage. This is how the individual market works right now. The plan leaves the market. If somebody doesn't enroll in a new plan, they're left uninsured. I think in terms of the Medicare program, nobody in this room will be surprised to hear this is really politically infeasible. The second option we're calling forced choice. And what I really mean here is we're going to take beneficiaries out of the choice process and force them into a plan, slot them into a plan. think that not only is this also politically infeasible, I think there's a real question of how you operationalize this. How do you force someone into an insurance plan that they don't want to be in? How long do they have to stay in it before they can switch out? For a lot of reasons, this isn't a viable option for us. And so a third policy, which we've called default choice here, is akin to the simplified active choice that we heard a lot about yesterday. Here, we're allowing beneficiaries, TCs, to choose a new plan for themselves, but should they not choose, either because they choose not to choose or because they make a mistake and fail to choose, there's a default plan that's selected that they end up in, so they do end up in a health insurance plan. The nudge philosophy would suggest that we choose a default that minimizes the welfare loss associated with ending up in the default plan. And I'll go over this very quickly. As we all know, defaults are particularly powerful in high-stakes decisions like choosing a health plan, and also when they're perceived to be endorsed by authorities. So in Medicare Advantage today, the default is traditional Medicare. If you're a TC and you fail to enroll in a plan, you go into the traditional Medicare program. This is a very different health plan than the Medicare Advantage plan that they chose for themselves. And importantly, over the last 8 years or so in particular, traditional Medicare has been less generous than Medicare Advantage plans, both in terms of the benefits that are covered and the cost sharing that's required of beneficiaries in those plans. So what we did in our analysis is we were really curious about the extent to which the TC's revealed preference for a Medicare Advantage plan and any potential effect of status quo bias to keep them in the Medicare Advantage program plays out against the default power of being enrolled in traditional Medicare should you fail to make your own choice. And the way that we did this is by taking advantage of the natural experiment that has occurred here in the U.S. Due to the flux in the supply side of the Medicare Advantage market. So the changes in plan availability that have been experienced across the U.S. have varied county by county. And so we have got some counties where we've got terminated choosers and other counties with similar sets of plans available to them where there aren't terminated choosers. And so what we did is we looked at the choices made by terminated choosers in comparison to non-terminated choosers, and we weighted the choices made by non-terminated choosers more heavily if you looked more like a TC or if you were in a plan that most similar to the plans that the TCs had chosen for themselves. So this comparison group of non-terminated choosers is weighted and includes both voluntary switchers and stayers. So in terms of our results, very briefly, what we looked at in the top are individuals who had Medicare Advantage HMO plan in 2006, and where did they end up in 2007? We can see that here, terminated choosers were more likely to go into traditional Medicare than were our weighted comparison group enrollees. We observed this also for terminated choosers coming out of an HMO plan in 2009. Here, the rate of transition into traditional Medicare was the highest, almost 10 times higher than our comparison group. And then also among enrollees in a Medicare Advantage private fee-for-service plan, in comparison to the weighted comparison group, they were also more likely to go into traditional Medicare. So what we're finding really is that the defaults seem to have some power among this population of TCs. And so as we think about the implications for choice architecture in the Medicare program, I think we're at a point in our work where we feel that while the optimal choice architecture isn't clear, it's not what we have. While traditional Medicare as the default mimics the initial default facing these beneficiaries when they become eligible, and it also potentially saves money for Medicare as current policy and payment is set up such that the government actually pays more to insure these folks in Medicare Advantage than in traditional Medicare. This is probably not the best choice for these individuals based on what we know about them if a similar Medicare Advantage plan is available. So I just want to conclude here and leave you with the idea of what else could we do, and I want to bring up the notion of moving towards a smart default here, where we can incorporate information about the TC's previous choices for themselves in setting up a default for them. in the face of a termination. And while I think this is particularly appropriate in a market where there are information problems, and in particular here where you worry about perhaps cognitive decline among an elderly population, and also the fact that a default might be perceived as sort of an expert opinion about what you should do, this certainly will introduce increased administrative complexity for the Medicare program, as well as require additional explanation and education and outreach for beneficiaries, which is also going to bring in some additional cost. So thank you.
Thank you very much, Anna. Our next speaker is David Tannenbaum from UCLA. His topic is default behavior as social inference.
Yes. So is there a way to do full screen? No?
Yeah, I guess.
Maybe that. Go to view and then full screen. Full screen mode. Great. Okay, can you hear me okay? Yeah? Okay, this work is with Pete Ditto at UC Irvine. Both Pete and myself are psychologists. The talk that I'm going to be giving today is a little bit different from what you've seen in that we're interested in these general psychological mechanisms that underlie default behavior, or why people tend to stay with the default. So the talk that I'm going to be giving today isn't really specific about defaults in a healthcare context, although I think it applies there, but about it's a story about default behavior more generally, okay? So just to make this a little bit more concrete, I want to give this example of retirement savings. We know that if we want to increase participation in retirement savings plans, then a very easy way to do this is to get employers to automatically enroll their employees into a savings plan. And so why do these defaults, why are they sticky? Why do people tend to stay with the default is, for example, in this case, retirement savings? Well, the kind of standard explanation, which is pretty obvious and which has been discussed mostly here at the conference, is some kind of idea of inertia. So people are lazy, or they procrastinate, or they show some kind of status quo bias. So this is what Dick Thaler calls the yeah, whatever heuristic. Kind of a complementary explanation, what's been hinted at in the previous talk, is that there's also sometimes when the defaults communicate information to these individuals. So in the case of retirement savings, let's take an individual who really does want to make a decision. So these are people who recognize that it's important, that they don't want to procrastinate, that they're not displaying inertia, but having to try to figure out what's the proper asset allocation, or how you should say for retirement, is a really complicated decision that has a lot of uncertainty. And one way in which they might cut through that uncertainty is to kind of ask themselves, well, why did the choice architect, why did my employer set this as the default? Why did they set, say, 5% as the savings rate? And they might think that, hey, you know, they have some kind of privileged information. Maybe they think that this is what's best for most employees, or this is maybe what most employees would probably choose for themselves. And so after drawing that inference, after some active deliberation, they end up staying with the default option, right? And so this has some interesting practical implications, and I would argue maybe also some normative implications, because we're not just viewing the decision makers as kind of inert, passive individual, and we can stick them in whatever default regime that we want to, but that it's going to depend partly on how they interpret and how they integrate that information when making these sorts of decisions. So I'm going to present a couple studies. The research questions in the paper that I have for the conference was basically looking at two questions. One is, under what conditions do people draw information from the default option? And we have a series of experiments that really delve into this. I'm not going to have time to go into the details, so I'll just give you the punchline. In addition to just the basic preconditions that they have to be motivated, they have to see the decision as relatively important, and there has to be some kind of uncertainty, is that there's certain types of default regimes, or there's certain types of choice architecture that are viewed as more informative than others, and in particular, opt-out or automatic enrollment defaults are viewed as more of an implicit recommendation than these opt-in or non-enrollment non-enrollment default. So this is just some results from one of the studies. What we did is we gave subjects, it's really straightforward, we just brought some subjects into the lab, we gave them some descriptions of various policies. So in this case, it was a banking policy. So this was for overdraft protection, whether it was an automatic overdraft protection or whether it was an opt-in overdraft protection. For the organ donation, it was the opt-in or opt-out. For medical testing, they learned about a hospital that either did a routine vaccination, so you're by default you get the vaccination unless you opt out, or an opt-in where they're told it's voluntary vaccination. If you want it, you can get it, as well as a retirement savings default. And then we just asked them, why do you think the choice architects selected the default that they did? And we kind of assessed this in a lot of different ways. But basically, what I'm showing you is the likelihood to infer some kind of implicit advice from the default option. And the blue bars are the automatic or the opt-out defaults. The green bars are the non-enrollment or the opt-in defaults. And as you can see across these, there's some variation, but across these different policies, what you're generally seeing is that automatic enrollment defaults are viewed as especially likely to communicate this kind of information. And we go to some length to kind of try to tease this out, to figure out why is it the case that you see this asymmetry. Turns out the explanation's pretty simple. Subjects subjects basically say, well, look at these automatic enrollment defaults are kind of viewed as more of an intervention. The policymaker is getting involved. They're opting me into something, so if I don't make a decision, my current state of affairs is being altered in some way. They view that as more of an intervention, and they reasonably assume that, hey, look, at policymakers don't get involved, they don't intervene unless they have good reasons for doing so. Whereas for these non-enrollment defaults, they just say, hey, look, maybe they're being passive, or maybe they're just trying to be hands-off, maybe they don't know. It's really hard to tell, so they don't really read into these defaults. They don't view it as communicating information about what the choice architect thinks or what they recommend. Okay? I think the more interesting question is what implications does this have? What are the kind of behavioral dynamics? And so I'm going to show you a field study that we ran. Again, this wasn't in a healthcare setting, but I think it shows some of the interesting behaviors that are going on. How much time do I have, by the way? Doesn't say right there. Yeah, you have 9 more minutes. Okay, great. Okay, but I think it shows some of the behavioral dynamics at play. Okay, so what this was it was in a classroom setting. So this was at UC Irvine. This was an undergraduate psychology course. There were 174 students in this course, and as part of the requirements for the course, they had to write 3 term papers, and these 3 term papers were worth 25% of their overall grade, and we set it up in the following way. We said that at the very start of the class, the first day of the class, we told them, you get to set your deadlines for these papers however you want. The only requirement is that they're due at the very last day of the class, but you can set whatever deadlines that you want. Once you set these deadlines, they're binding. You can't revise them. If you turn in a paper later, you get penalized, just like if it was an externally imposed deadline, and you're not going to get any kind of early feedback on these papers. But if you want to, you can always turn them in early. There was an electronic Dropbox, which they could just submit them to. And what we did is we manipulated the default schedule, which I'll show you in a second. But the reason why we set it up like this is that we wanted, the design takes the kind of following properties, is that we're not providing any external incentives for them to turn it in early. So you could argue that there's an optimal kind of allocation here, which is just to set all of your papers to the very last day of the class, because that gives you the most flexibility, that gives you the most time to learn the material. But at the same time, if you realize that you're not in econ and that you're susceptible to procrastination, and you wait till the last minute to write a paper, if you do that, in this case, you're waiting till the last minute to write 3 papers. Whereas if you kind of impose these costly deadlines on yourself, you're kind of forcing yourself to kind of allocate more time to these papers and potentially write a better paper, okay? So this is just a kind of overview of the way it looked. So they were told all this information on the first week of the class. There's 10 weeks in the quarter. They were told that they had to indicate their preference by the end of week 2. After the first day of class, they were given an email with a link that said, hey, look, when you go online, you can fill out your deadline preferences for when you want your papers to be due. And what we did there is we manipulated between subjects. So half of the class got one default allocation, the other one got another. So one of the defaults that they saw is what I'm calling the staggered defaults. They just basically space them out at papers are due at weeks 4, 7, and 10. Again, this is just a default allocation, so if they want to change it to something else, it's very easy for them to do so. And then for the other half of the students in the course, they see what I'm calling the lump default, which is basically just putting, the default is just for all papers to be due at the last day of the class, but if they want to impose these costly deadlines, if they want to move these deadlines forward, the free to do so. And what we expected is that basically that they would be more likely to draw implicit advice from these staggered defaults because they're seen as more of an active intervention, just like automatic enrollment in the other cases that I showed you, whereas the lump default is kind of viewed as more kind of hands-off, laissez-faire, doesn't really tell me what the instructor thinks. And so as a result, we just expect that the staggered default, we're gonna get a little bit more action on default behavior in that case than in the lump default, okay? So here are the results. Did the default actually matter? Did the default setting? The answer is yes. So what I'm showing you here is the subject's responses or the proportion of deadline preferences over the course of the quarter. So this is for the staggered default. Recall that the deadline allocation is weeks 4, 7, and 10. And what you see is these spikes at weeks 4, 7, and 10. Roughly 75% of students are just staying with the default. And then what about the lump default, where all 3 papers are due on the very last day of the class? What do we see there? We see a lot of them staying with the default allocation there. So we're getting very large default behavior. We also have an indication that this actually affected their, basically their behavior, because we were able to get a timestamp on when they turn in their papers. The story there is basically they wait till the last second to turn in their papers. So in this case, they're waiting till the last second to turn in 3 papers. They're actually more likely to get late penalties in this condition than in the other because they procrastinate and they kind of fail to anticipate that they have to write these 3 papers. Okay, second question. Do the students view the default as conveying some kind of implicit recommendation, at least under certain conditions? So halfway through the quarter, in the guise of a mid-quarter evaluation, we said, hey, we'd like to get your feedback on all these different course policies, because we might be making tweaks next year, so your honest feedback would be appreciated. And we asked them a bunch of questions about all the different policies in the course, and embedded within that was some questions about this task of setting their own deadlines. We asked them, did you like to have the opportunity to set your own deadlines? The students overwhelmingly said yes, which is kind of interesting given that everybody kind of stayed with the default. They didn't view it as confusing or complicated or anything like that. And we also asked them questions about the degree to which they viewed it as an implicit recommendation by the instructor. So we asked them these questions like, hey, do you think that the instructor set this as the default because they thought that students would do best under this kind of regime? Those sorts of questions. So we had a series of those. And what we see is that, I think this little thing right here is blocking it. Let me see if I can move that. There you go. But under the staggered default, that's the 4, 7, 10, they're more likely to draw that sort of inference than they are under the lumped default. More importantly, did those sorts of inferences actually affect their behavior, their decisions, their initial decision about whether or not to stay with the default allocation? And it turns out that yes, that was the case. So what I'm plotting here is the probability of staying with the default option as a function of the degree to which they endorsed that the default signaled some kind of implicit advice. And what I'm showing you here are the predicted probabilities. And as the more likely they view the default as conveying information about some kind of implicit endorsement, the more likely they are to stay with the default allocation. And then, since they're making these social inferences, they're starting to think about, hey, why did the instructor select this as, as the particular default allocation? Is that there's these other social contextual cues that come in, and I think this is where it starts to get a little bit interesting about why viewing defaults as implicit recommendations are different from things like status quo or other types of inertia. So there is a little bit of research out there suggesting that if the choice architect is viewed as untrustworthy, that sometimes you get these backfire effects. So, hey, they're opting me into something. I don't trust this person. They're probably doing it for their ends, not for my own, so I'm just going to do the opposite, right? So if the fact that automatic enrollment or an opt-out or the staggered default in this case is more likely to communicate this kind of information, then you would expect that trust should really matter in those cases. Whereas if the default is viewed as not really conveying any kind of information, then trust shouldn't matter, right? Because it's only if I think that the choice architect selected this as a default for a particular reason, then I'm going to start to assess, hey, are those reasons in my interest or against my interest? So that predicts some kind of interaction between the type of default regime and the degree to which they trust the choice architect. So we did ask them in that mid-quarter evaluation some questions about their general beliefs about whether instructors at UC Irvine are trustworthy or not. So these are items like, how much do you agree with a statement that in general instructors typically have their students' best interests in mind, or that they have a solid understanding of how to structure the course, or that they have no idea what they're doing? And we asked a series of these questions, and it turns out that you get quite a bit of variation in the degree to which students view their instructors as benign or not so benign. So what I'm plotting here is the probability of staying with the default option as a function of the degree to which they trust instructors. And so as you go further out on the x-axis, that means high trust. As you go further in, that means low trust. And so what I'm going to show you first is for the staggered default. This is the 4, 7, 10. This is the one that they viewed as conveying an implicit recommendation. And as you would expect, the more that they trust the choice architect, the more likely they are to stay with the default option. As trust goes down, this is on the left side over here, as they become increasingly distrustful, they're less likely to stay with the default option. What about for the lump default, which was kind of viewed as kind of hands-off, not really telling me what the choice architect thinks? We would expect that you wouldn't see that much action as a function of trust, and indeed you don't. The slope is negative, but it's not significant. So another way of saying that is that it doesn't, under these sorts of regimes, it doesn't matter whether the choice architect is viewed as trustworthy or not so trustworthy, because they're just not getting any information in the first place about the choice architect's reasons. Okay, so I'll wrap up. There was a lot going on there. Just the kind of take-home points is that, you know, default behavior sometimes happens or often happens because of inertia, but sometimes it's through active thinking that individuals sometimes view defaults as these implicit recommendations. This is especially so whenever the default or the choice architect is viewed as especially kind of like an intervention, so they see it's very clear that the choice architect is involved in some way. These inferences influence the degree of effectiveness of these different default regimes. And finally, that under certain conditions, the policy effectiveness is going to depend at least partly on this relationship between the choice architect and the individual decision makers. So if we have a lot of trust in the choice architect, or sorry, if we're operating in conditions where there's a lot of trust, where the individuals trust the people that are making these sorts of decisions, then defaults and other forms of choice architecture are going to be a lot more effective. Okay, thanks.
Thank you, David. Next is Elliot Dooms, Counsel with the U.S. House of Representatives. He's going to be presenting his paper on mental health entitled How Choice Architecture Can Define a New Era of Providing Mental Health Treatment.
How you doing? My name is Elliot Dooms. I'm presenting this paper with my co-author, my wife, Dr. Aeva Gaymon Dooms. And I guess to kind of put it in some context, my experiences with federal real estate, and this paper is born out of my experience in a discrete instance in the local DC real estate market, had changed dramatically, but agency executives have been slow to respond. So Congress changed the default in how they approach the real estate market in order to change the baseline of how they procured space in order to achieve savings by pushing them towards neighborhoods that were formerly forlorn, but now were pretty nice and a great place for federal agencies to go to save money. I think my observations about that and my discussions with my wife, who I mentioned before is a child and adolescent psychiatrist, is how the landscape had changed for mental health in the United States. You know, there was a dramatic change, but the question was how we could use this dramatic landscape change to make folks healthier. It's helpful to begin this discussion with an understanding of the scope of the problem. The federal surveys that estimate that as many as 50 million Americans suffer from mental illness in the last 12 months, and with a little bit over 9 million suffering from serious mental illness. That's a lot of sick people in need of medical help. But I think the problem is we don't regard problems like depression the same way we might regard someone that has a problem with their knee and is in need of arthroscopic surgery. The reality before the ACA, there was not widespread recognition that mental illness deserved the same attention as surgical and medical services. And that's what's so important about the Patient Protection and Affordable Care Act, no matter how you feel about it in the subsequent rulemaking. Affordable Care Act was a dramatic reworking of the healthcare landscape in the United States. You know, now with the ACA, most insurers that currently offer mental health services are required to offer them in parity with medical and surgical benefits, which means for the first time, there's going to be a parity with respect to annual and aggregate lifetime limits, treatment limitations, financial requirements, and in and out of network covered benefits. the ACA built on some existing parity laws by expanding the applicability of parity to a number of additional plan types, including plans on the exchanges, where mental health benefits are now considered an essential health benefit. HHS, the Health and Human Services, estimates that 60 million Americans will now gain access to these new mental health benefits, a group that includes the previously uninsured and people in the individual and small group markets. So before the ACA, we had a problem of, we've got all these people with mental illness, but spotty coverage with the type of medical benefits necessary to address this pretty well-documented need. Okay. The problem of not having mental health benefits manifested itself in the market for services for psychiatrists and other mental health professionals. We refer to a recent study published in the Journal of the American Medical Association of Psychiatry that about 90% of other specialties take private insurance, but only about 55% of psychiatrists did. Low reimbursement rates was cited as one of the reasons as to why they did not accept insurance.
I just want to make sure that you're not trying to advance your slides, are you?
I was.
Okay, they're not advancing for you.
Yeah.
So let's just,
Okay, great, thank you.
so just get to where, I'm not sure where you're supposed to be. Sorry.
Sure. I think I was talking about the Journal of American Medical Association of Psychiatry found that 90% of specialties accepted private insurance. And say, psychiatrists and other mental health professionals, they didn't accept insurance. And one of the reasons why, they didn't feel like they were being reimbursed at a rate. So this distorted the market. And you know, these federal parity rules began to address this problem and perhaps persuade and incentivize more medical students to go into psychiatry and encourage more psychiatrists to accept insurance now due to these federal parity laws. You know, access to good mental health care, we believe, can be divided into roughly two major challenges. One would be creating the financial incentives for mental health professionals to take on patients and removing financial barriers to the millions of Americans that might be willing to see a mental health professional, but now they'll have the insurance necessary to facilitate this easier access to treatment. You know, the next barrier that we have to begin to talk about is stigma. There's a significant amount of research that suggests that stigma can play a powerful role in the lives of those suffering from mental illness. Stigma can stop people from seeking treatment. Stigma can lead to non-compliance with treatment, and it's not insignificant in accessing mental health care. So, you know, this is further gone by the stigma in popular culture with the portrayal of popular television and movie characters with mental illness. And even though they're often portrayed as violent, mental illness doesn't contribute to violence nearly in the way that you would expect based on the portrayal by the Screen Actors or as studied by the Screen Actors Guild about how mental patients or people suffering from mental illness are portrayed. So when I talk about stigma, I want to talk about ways to address stigma through protests, education, and contact. And that leads to the meat of what we're proposing, which is wide-scale adoption of mental screening in both schools and the workplace. And this is done with a thought that, you know, it would have to be done on the local level. And part of the reason on the slide is, you know, we have that now. You know, public health, we accept vaccinations as a wide-scale public health initiative because we believe it works, and we understand that it can have a great effect on people's health. You know, eye and hearing screening, as well as now one of the most recent introductions to these large-scale public health obesity screening. And we are proposing the same for mental health. I mean, we know a lot of people suffer from it. Now it's a reimbursable service. Our vision is that this initiative will be seen like just any other public health initiative of the last century. The goal would be to screen en masse with the idea that young adults and adults that are identified as struggling or suffering from mental illness would be able to have access to more thorough assessments if necessary that would now be subject to, in most plans, full reimbursement by insurers. And the reason we're focusing on young adults and people as they're entering the workplace, we know that roughly 75% of behavioral disorders manifest themselves before the age of 24. Targeting this population would allow for early interventions, and there's been some research to suggest that there are significant savings by addressing mental illness early as opposed to later. We're also proposing this in the workplace. To an extent, many workplaces already offer these services, even though they aren't mandatory. They're more commonly referred to as employer assistance plans that offer people the opportunity to meet with the counselor, do screening, and get the type of mental health benefits that we know kind of make sense. But once again, we have to address the issue of stigma. And if you create a default and move towards requiring everyone to do this, obviously not everyone is going to want to use these services. There are, I think, cultural phenomena, cultural practices that might make it part, and even some partially based in religion. But there are real benefits to these programs, and I think we've tried to take a look at some of these employer assistance programs and some of the research on those, and that these benefits have been well documented, and that if you treat people that are suffering from mental illness, you're talking about less employee and absenteeism, less turnover, less presenteeism, people showing up but not really working, and more enhanced working engagement. And investment in these programs have real cost benefits, with estimates is anywhere from up to $3 to $10 for every dollar invested in them. We anticipate that these mental illness screenings and assessments will be guided by the same guidelines used to protect vital and private health information for other types of maladies, a confidential medical record. Screenings done at work would be expected to fall under the American Disabilities Act, where employees would be protected from adverse action from their employers unless their illness was directly related to the job. There's been at least one recent court decision in the Sixth Circuit Court of Appeals that ruled that a mental health evaluation was a medical examination for purposes of the American Disabilities Act. And that further brings me into a more unfortunate aspect of what we're talking about. And I guess we want to stress that the connection between mental illness and violence is a lot of times portrayed in popular culture as being direct, but there's a lot of violence in our country that is not related to mental illness. But what we do know is that with the proliferation of mass shootings and the problem we have with workplace violence, that we know what can happen at the extreme end of the spectrum when we have mental illness that is untreated. We know since the Sandy Hook shooting in December 2012, there have been at least 44 other school shootings, and the current administration has directly tied their efforts to reduce gun violence to increase access to mental health treatment and federal parity. Point out that many of the worst incidents of mass shootings have been tied to shooters with a history of mental illness. We recognize also that screenings and assessments will not necessarily make a patient compliant, but our goal is through contact and providing people in a wide scale the ability to have contact with the mental health field and practitioners to ask the questions to destigmatize this. And the goal of having these mandates is to normalize mental health treatment, to address stigma, and ultimately to make it easier for the general public to assess treatments. Thank you.
Thank you very much, Elliot. Very interesting. And batting cleanup, David Orntlicher, Indiana University, speaking about presumed consent to organ donation.
Well, thank you to Petrie-Flom for giving me a chance to participate in this terrific symposium. And it is fitting that I'll finish up because I'm going to tie back to Russell Korobkin's very nice start for today. And I'm going to reinforce his view about presumed consent to organ donation and expand on that and explain in more detail why he's right that this is just not a good fit for the libertarian paternalism model. To be sure, it's not surprising that we would see Thaler and Sunstein and other nudge theorists identify presumed consent to organ donation as a good example to use nudges. We know that under our current system, right, we assume you don't want to be an organ donor after you die unless you affirmatively choose it or your family does. And as a result, lots of organs go wasted. People are waiting, I think, as Russell showed, over 122,000 people waiting. And lots of people die while waiting for organs, and we don't use all that could. If we had presumed consent, we assume people want to be an organ donor. Unless they opt out, then we won't lose so many organs. And in fact, and we'd still preserve personal autonomy. We're not forcing you to be an organ donor. If you don't want to be one, you opt out. But we want to make sure that we get the organs that people really are willing to donate. And if you look at public survey data, it does seem to suggest that there's widespread support for organ donation. So according to the most recent data I found, more than 62% of adult Americans report that they have actually granted permission through their driver's license or by going online at Donate Life America, some other way they've said that they want to be an organ donor after death, 62%. And of those who haven't, the 38% who haven't given permission, 60% of those say they probably would or definitely would want to be an organ donor. So based on public survey, you get about 85% of adult Americans say they're willing to be or probably want to be. And in fact, too, another piece of data that's very interesting is if you look among people who become organ donors after death, now 40% of them are designated donors, people who actually gave permission before they died, and that's doubled since 2007 when only about 19%. So lots of good reasons why we might think nudge theory would work, and also if we look at the principles of nudge theory about the frailties of personal decision making, as David talked about, we have the status quo bias that if we set the default rule at opt-in, then people will be inertia or maybe the signaling effect, that's the recommended policy. So if we can switch to the default rule, then presumably we'll overcome the inertia bias and the signaling that leads people to stay with the opt-out, decline to opt-in when that's their true interest. Another reason that nudge theory suggests that there may be problems with decision-making with presumed consent to organ donation is the short-term, long-term problem, right? People are, if there's a short-term cost, that may prevent them from doing what their true choice is for the long term. So people don't like to confront their mortality, and so that short-term reluctance may lead them to not talk about organ donation or make a decision about organ donation. That would really be their preference. Okay, so it seems pretty good. But let me talk about now why I agree with Russell and why I think presumed consent is not such a good idea. There are a few reasons, for example, why arguments against presumed consent, opt-out policies can disfavor the poorly informed, the poorly educated who may not be aware of the system and the need to opt out. So a lot of people who really don't want to be an organ donor may not choose to opt out because they're just not aware of it. The also thing I think we have to be skeptical about the public survey data. As I said, the strong case is that 85% of Americans, this is what they want. But of course, we know that people, when answering surveys, tend to give the socially favored answer rather than their true answers. So while 62% of Americans have said that they've actually agreed to be an organ donor, if you look at how many of adult Americans have actually signed up, are in organ donor registries because they agreed when they got their driver's license, it's actually only 45% of adult Americans rather than the 62% who said they've done it. The other thing that's important here, we have to worry about risks of error, right? So if we have an opt-in system, the risk of error is somebody who really wants to be an organ donor doesn't get to be an organ donor, so their wishes are not fulfilled. In our presumed consent system with an opt-out, our risk of error is somebody who really doesn't want to be an organ donor, fails to opt out, or we don't recognize that they've opted out, and so they become an organ donor against their wishes. And so, as in the example of the criminal law, right, it's much worse to convict an innocent person to let 10 guilty people go free. Same here, which is the greater harm, to turn somebody, an unwilling person, into a donor, or not to take organs from a willing donor? And I think it's worse to take organs from an unwilling donor than to forego organs from a willing donor. Partly because people worry more about losing something they wish to keep, right? If you want to keep your organs and you lose them, that's more distressful than the person who wanted to be an organ donor but doesn't get that opportunity. The other reason why I think that's true is if you look at lawsuits, there are a number of lawsuits where somebody didn't want to be in, usually they're corneas, but sometimes organs, where they're taken over the objections of the person or the family. Then you get lawsuits over that. You shouldn't have taken the organs, we didn't want them taken. But I haven't been able to find an organ a lawsuit by a family member where they wanted to be an organ donor and they didn't take the organs, and then the family said, you're supposed to take those organs. The only thing that comes closest is there was a case where a guy wanted, the family said, well, he's got a good friend who needs a kidney, give his kidney to the friend, and they sent the kidney off to Florida instead of giving it to the friend in New York. There was a lawsuit there, but not for failing to take the organs. The other concern that Russell talked about is the concern about risk to health, and this is complicated. I think he's right to point it out that in a presumed consent system, physicians may start to see people more as potential. We can use their organs after they die. Are they going to treat them as aggressively? So there's that concern. And finally, to also suggest that these concerns are realistic is the empirical evidence is not very good. There are a number of studies that suggest if you look at European countries where they have presumed consent, you get more organs. But not all the studies go that way, and there's good reason to think that other factors are much more important than whether you have presumed consent, that the infrastructure for organ transplantation is much more important. And the good example there is Spain. Spain is the poster child for presumed consent, because Spain has the highest rates for organ retrieval in the world, and they have presumed consent. So you commonly see, look, Spain's got presumed consent, they have the highest rates of organ retrieval. However, when you look more closely, it turns out that may not be what's going on. Spain did enact presumed consent in 1979, but it doesn't have an opt-out registry. It also doesn't have a public awareness campaign to advise citizens about the opt-out. And in fact, families are always asked for consent, and the family's wishes prevail. Spain's retrieval rate, which is high, did not actually rise until 1989, a decade after presumed consent law was implemented. And what seems to have really gone on, what happened in 1989, they implement this highly organized national transplant system. They have active and well-trained transplant coordinators at every hospital where organs are retrieved. So it really seems that these other measures, rather than presumed consent, are going on. And US data suggests that's true too. If you look across organ procurement organizations to see what they call their conversion rate, what % of potential organ donors turn into actual organ donors, and it varies from 50% to 87% in the country, and the ones that seem to do a better job talking to families and doing it approaching them in an effective way get more organs. So one thing I think I can say with confidence is that you don't need presumed consent to get very high rates of organ donation. Maybe the best case for presumed consent is kind of the signaling effect. If people know that's the rule, then the families might be more likely to say yes. So let me now tie back to Russell. So, the empirical data aren't very good. People are not, even where countries have presumed consent, they still ask the families. And I think this reflects a general reluctance to really implement presumed consent seriously. And I think that's because, as Russell said today, really, presumed consent really doesn't fit the libertarian paternalism model, right? The idea there is that we're trying to help people realize their true preferences, make decisions that reflect their real judgment, not to do something that's good for society, but what they think is good for, based on their own judgment. And we can be much more confident to do that when we're asking people to act in their self-interest. Being an organ donor is a very good thing to do, but it's not a self-interested thing. It's a very altruistic thing to do. When we look at the examples that Thaler and Sunstein give, the more persuasive one, the retirement plan, it's in my personal interest to set aside money for retirement. It's in my personal interest. The other example they give is simplifying insurance plan, descriptions of insurance plans, so I can understand the choices I'm making. Their persuasive examples are when people are acting in their self-interest. With organ donation, you're being asked to do something that's not in your self-interest and that may actually be against your interest. In two ways. One is for people who care about their bodily integrity, you're being asked to agree to a violation of your bodily integrity, and for some people that's very important interest, and in fact it's an important interest in law. We're reluctant to ask people to accept impositions for the benefit of others, especially when it involves an invasion of bodily integrity. And then even worse, if there is a risk to health. As I say, I'm a little uncertain about that, but I think there is a legitimate concern that in a presumed consent regime that doctors might be more likely to see patients as potential organ suppliers rather than patients who need treatment for their own sake. And we certainly know that patients worry about that. When you look at why do families not agree to organ retrieval from their deceased family member, one of the important considerations is the fear that it'll affect the way doctors treat them. Will they treat them as aggressively? So in short, I think there are good reasons to have presumed consent and to encourage people to be organ donors, but I think Russell was right. This fits much more in a libertarian welfarism model than a libertarian paternalism model. So I look forward to your questions, and thank you.
Thank you very much, David. And Glenn, it's okay if we take a few minutes for Q&A. So while people are moving to the mic, I'm going to begin the questioning, and I'm going to ask Anna Sinaiko to talk a little bit more about Medicare Advantage, because it's been, Anna, a target for cost savings in Medicare. The administration has been looking to that program to pull out a fair amount of money. I think that overall the expenditures are 13 to 14% higher in Medicare Advantage than traditional Medicare. So could you talk a little bit about the implication of your findings for this policy in terms of a potential focus for cost savings in Medicare?
Sure. Yeah, thanks for the question. Absolutely. As it is currently being operated, it is the case that because of how payment is made to the health plans over the past certainly 5 years and closer to 10 years, it's been estimated that Medicare, the government is paying more to the Medicare Advantage plans to insure individuals than they would had those individuals been enrolled in the traditional Medicare program, on the order of about 13%. And so the way that the default for TCs is set up now, to the extent that it has power in influencing people's transitions when you're TC back into traditional Medicare, as the program's currently being operated, that's saving the government money. To the extent that we change the default policy so that those individuals are more likely to stay in MA, if things operated as they continue to, we would spend more for them, which would not help us with our cost situation in the Medicare program. The caveat here is that payment policy is continuing to change, and the way in which the government is going to pay plans is changing over time. It's been legislated in the ACA in particular, and so the idea is that in general, payments to Medicare Advantage plans will go down, and so we won't be overpaying or paying more to insure those individuals in Medicare Advantage. And in fact, we may have the opportunity to take advantages of the practice by managed care plans at more efficient provision of health care and realize some of the efficiencies to be gained from having those people in those private plans.
Hi, Moti Gorin, Bioethics and Health Policy, University of Pennsylvania. I have a question for David Tannenbaum and also a comment or maybe a suggestion. The question is whether, to the extent that your studies show that it could be a system 2 phenomenon that explains why people go with a default, do you see this result as sort of consistent with the broader libertarian paternalist sort of paradigm and program, or do you see it as undermining one of the sort of central evidentiary bases for that program? Right? Insofar as defaults are seen as one of the most powerful tools for affecting behavior, if it's a system 2 phenomenon, not a system 1 phenomenon, then what we thought might have been going on really isn't. It's just people deliberating rationally about what they ought to do, and it's not that interesting. I mean, it's interesting, but it's not interesting qua sort of nudge or something. So that's the question. The comment has to do with how we understand what it is for a default to serve as a recommendation, right? So very often in the cases that we're looking at, the advisor and the advisee, or the recommender and the person getting the recommendation, are sort of in, not only are they in epistemically different positions, but they're sort of power dynamics that at play. So one thing you might think going on, one thing that could be going on is, I'm an employee, I don't know a lot about retirement savings, my employer presumably knows more, I'm gonna take that advice because that person is sort of my epistemic superior with respect to these choices. Another thing that might be going on is, well, it's my boss, right? Or I'm getting this person is making me a recommendation the same way that the mafia makes a recommendation, right? So it could simply be I'm following what it amounts to something like a command rather than an epistemic superior. So is there a way to differentiate between those two, given the studies that you looked at? You have a hunch for the extent to which authority might be playing a role versus epistemic considerations. Thanks.
Yeah, that's a great point. My sense, I don't think the data can really speak to this. My sense is that it's typically usually the former, that they kind of think that the choice architect has some degree of kind of privileged information. But I think you make a great point that whenever you set these defaults and they communicate information about what the choice architect or your boss or whoever it is thinks what you should do, or even if it's a reflection of majority preference, so it's a reflection of what most people prefer, that it's communicating information about norms. So it's either norms about what you should do or norms about what's kind of descriptively normal, right? And so that brings in the possibility of coercion or of even stigma, right? If that, hey, if the default is communicating that most people do X, but I really prefer Y, does it make me feel a little bit of uncomfortable to do Y, right? I mean, you could think of a real example of this is in the UK. I don't know if they've actually implemented it yet, but they've talked about setting an opt-out for porn filters on your internet service providers, right? So you could think that people feel really kind of stigmatized or uncomfortable if they have to go in and change the settings to say, yes, I want to look at porn, right? So I think that that's one example. But what I would say, and I imagine what Cass and other libertarian paternalists would say, is those are all relevant considerations, and those should just be, these informational effects should be kind of considered as part of the kind of decision costs or potential benefits or harms to welfare. To your point about does this undermine libertarian paternalism, as far as I see it, I don't think so. I mean, it does say that at least in some instances, people aren't just being lazy or dumb, but they're actively thinking about it. But what I take the central point of kind of libertarian paternalism to be is that you can steer people, broadly defined, while not kind of forcing their hand, that you make it, if they want to actively exercise their preferences, they're free to do so. So in this case, when the individuals are thinking about it, And, you know, whether they actively think about staying with the default or whether they switch to something else, you know, you know, they're free to do so. But about the kind of the steering part, sometimes we see it as we're kind of steering them under the radar, especially for people with weak preferences who just don't know what they want. In this case, where they're actively thinking about it, we're just providing them with information. So that's, I guess, another form of steering, but it's a bit more participatory, where the individual is either accepting or rejecting that information.
Nina Cohn, Syracuse University. One quick comment relative to that, and then a question for David on organ donation. One way you might get at that is, you know, do the students think that there is an implicit penalty if they don't comply, right? And correlating what they're doing with professor popularity, their feeling about the fairness of grading, and even potentially professor gender would be very, very interesting. My question on the organ donation presentation is this. In most of this conference, we've been talking about nudges that providers or governments provide to patients. And I think perhaps the phenomenon you're describing, David, with regard to organ donation, suggests that patients are nudging their doctors. That they are saying, perhaps, I want you to provide a little bit more care, or I want you to have to talk to my family. And I wonder if maybe we should also be looking at some of the nudges patients provide their doctors.
That's a very interesting point. That's a good way to look at it, and I'll think give some more thought to that. Yeah, the other thing I think that's going on too. I wonder if this ties into Kristen Underhill's crowding out that. You know, the Brazilian experience kind of suggests that when they passed a presumed consent law, that people just picketed and down at City Hall or whatever wouldn't be City Hall, but some public building. They just had to pull it back right away. That you know, this idea that maybe I'll be an organ donor, but I want you to let me make the decision, not force it, because after all, I also said that Spain does get very high agreement rates. So yeah, it does seem like people are much more willing to do this if they're not the strong-armed and feeling like you're assuming I want to do this and
Hi, Rosanna Summers. I'm a graduate student at Yale. This is a question for Dr. Tannenbaum, related to Modi's question earlier about whether your findings are problematic for libertarian paternalism, but I'm focused on your finding that there's sort of an asymmetry in how strong the perception of policy recommendation is for opt-in and opt-out. I really read that finding as challenging a very popular defense of nudge, which is that, you know, nudging is inevitable, and the related claim that there is no neutral default. Opt-in, opt-out, they both nudge. You know, in the original Libertarian Paternalism is Not an Oxymoron paper, Sunstein and Thaler say that, you know, with regard to retirement, there's no law of nature that says it has to be opt-in, opt-out, and opt-in both alter choices, so what's the difference? I take your findings as saying, though, that maybe some defaults are more neutral than others. Maybe with opt-in, people read less of a policy prescription than with opt-out. And so my question for you is, what do you think of this claim that nudges are justified based on the fact that there is no neutral default? And second, do you think that the right default is the one that carries the weakest policy prescription or perception of policy prescription because that is sort of the most neutral in the eyes of the chooser?
Yeah, I think that's a great point. On the last part of your question about what do I think is appropriate, I think that that's just a normative statement about the degree to which you think that policymakers should be involved in, you know, the degree basically to which you think policymakers should be involved in these individual decisions. So I can't really speak to that. I think that that's just kind of a, you know, each individual's preference on the degree to which you think paternalism or libertarianism is appropriate. But to your point that, yeah, that opt-outs have this additional channel of influence, right? So there's also, in addition to inertia and status quo bias, that some defaults communicate information more than others, and so there's this additional channel of influence. So yeah, you could say that it's more paternalistic in the sense that it's, you know, it's pushing people a little bit stronger. But you could also say that it's kind of activating, the degree to which people are engaging in rational deliberation. So, in the opt-in case, although it's not really sending the signal, the only reason why people are getting moved around is because, they're not really thinking about the choice. Whereas in these opt-outs where they're really actively thinking about it and, saying, yeah, I agree with this prescription or I disagree with it, you could argue that, by appealing to kind of rational deliberation, that it's being more libertarian. So I think, it makes it kind of goes in both ways for different reasons.
With apologies to those left in the queue, I think we're going to have to end it there, but a big round of applause for this panel. And let me just thank you all. We have a lot of events during the year. We hope you'll come back for many, but this one felt quite special. We loved the participation. We love the people involved, and we're hoping to be able to turn this into a book soon. So thank you very much. If you have any questions, please let Holly or I know. And once again, I encourage you to fill out those feedback forms and leave them in the front so that we can do an even better job next year. And once again, a big thanks to Holly and Chrissy.